Good morning. It's wonderful to be together with smart people. So in the next 15 minutes, 10 minutes, I'm going to talk to you about this topic that I really love to do. And I have nothing to disclose. I usually pass my time, so I like to start with the conclusion so I can give the message to start with. So when we talk about this topic, I think the one thing is that we need to know it's all about what exactly we're calling the Crohn's disease. What does the patient want? This may be the earlier slides that you may have given to you. Do you have the one that I gave it to you last night? If it's not, I can continue this. Okay. And what are the multidisciplinary workup findings has showed? And when you deal with these patients, whether it's failed, revise, or reconstruct options are all on the table. Complicated liberal medical therapy if concerns Crohn's disease is high. And patient needs to understand the long-term relationship in these settings. The critical thing in these settings it's really important. Let me just go there because this is the wrong template. But let me just tell you about the failed pouch. The failed pouch, it needs to be a patient-driven agenda. And this is my biggest principle that I always tell. If one can live happily and a good quality of life with a stoma, trying to convince them for a redo pouch surgery is the greatest disservice. So it's quite all right for the patients to live with a permanent ileostomy. One, when cannot live with happily and a good quality of life with a stoma, trying to convince them for a pouch excision is also a great disservice. So why I'm saying this thing, because all these, the patients go out there, they're desperate. They want to try to avoid a stoma. They cannot live with that. But we have a surgical practice in our, the country, just take it out. When someone don't have the merit and the skill set, try to convince them not to do a redo pouch is also a very big service. When you talk about the principles of the reoperative pouch surgery, it needs to start with the humility. The humility, and it's about the teamwork. Teamwork about the whole group practice. Respect, patient, pathology, unpredictability, and OR staff, and strategizing is very important. And repetition is the mother of the skills. This is a surgery that needs to be done in the team's practices, does it every day as a group, not once in a blue moon. So let me just tell you for a gastroenterologist that which you commonly see. And this is really the sad part of the situation. 53-year-old female, 20 years of history of ulcerative colitis, presented with a low-grade dysplasia, surgery in 2003, one-stage pouch, and no ileostomy and mucosectomy. That last sentence, get a gun and shoot himself is the same thing. And this is a guy, a surgeon who does this 5 or 6 of these things on a yearly basis. So there's major medical or infrastructure, the system problem that we have in our country where this procedure, unfortunately, is not being done at high volume centers. My passion is, to be honest with you, if you're going to be doing something, pediatric surgeon, the gastroenterologist, or a colorectal surgeon, you really need to be subspecializing in this field. Trying to do this in a once in a blue moon is not going to help anybody. It's going to create more problems like the one that I'll be sharing you right now. Postoperative events, she had all these things problem. Guess what? Diagnosed with the Crohn's disease, post-op delayed diagnosis of Crohn's disease, and the patient was treated with infliximab for years. Now, what does that mean? So this becomes now your problem to deal with. Suddenly, all these things that's treated as the ulcerative colitis with years, suddenly patient became a Crohn's disease. So when you get these patients, I think the critical thing is reevaluate the technical failure. Check your own, their footsteps, because most of the time, these patients, they have a unique problem. History is about everything. Patients comes to me with these big piles of the files and everything. I just ask them, what happened after the pouch surgery? What exactly happened? If they tell me the fact that, Dr. Remzi, after the second stage of the pouch procedure, I had a major leak. I had an infection. This patient does not have a Crohn's disease. This patient had a surgical problem. Now the surgeon washed his or her hands, sent the patient to you, telling the fact that I did what I could do, likely that this patient has a Crohn's disease. Exactly what happened to that patient. She never had a Crohn's disease all life long. Major leak, infection, fistula, now we got a Crohn's disease to deal with. Now, when we look at our results, when I was in Cleveland, this was the story. Up to 80% of the patients that was referred was actually misdiagnosed as a Crohn's disease and treated as a Crohn's disease with a J pouch. And these patients were candidate for a redo J pouch itself. So the thing that we need to accept and know the fact that 2 to 7% of the IPA patients usually will get complicated by a Crohn's disease in their lifetime. But mechanically fixable reasons may be mislabeled as a Crohn's disease. So patients undergoing a redo ileopouch anal anastomosis between the last 2 years I've been at the NYU, we looked at. And this is the studies, and this is the same saga continues. 77 patients less than 2 years were sent for a redo pouch procedure to NYU. 52, like 70%, have been treated as a Crohn's disease for years before referred to us. 43 had a redo, 9 are being preferred for a redo. And the results are very good, at least at the short term. Pouch rotation rate over 97%, 1 redo failed. So conclusion, mechanical defects can mimic Crohn's disease. Short interval between index IPA and onset of the symptoms should raise question. And redo IPA is a viable option if mechanical defects are found. Why I'm putting this thing up? It's a lot of gibberish down there, because it's really a complicated procedure when you have the privilege to take care of these patients. Because the art of the redo pouch surgery needs a strategy. When these patients come so much drained, they're complicated, suffering for years, quote unquote, labeled as a failed pouch or a Crohn's disease, you need to recondition them. Most of the time, I like to give them an initial ileostomy if they don't have one for 6 months to be able to build them up. Not just the patient, but also the family. So, and also it is very important to strategize the area, because the art of the complex colorectal surgery to see the things a couple steps ahead. This is the patient who had a J pouch itself that leaked. You need to position this ileostomy to a position, because if you cannot use this old pouch, which can happen 40% of the time, you can bring this ileostomy as a new J pouch, hook it up to the anus. And that is the complexity of the procedure, that you need to be able to see the things a couple steps ahead. And when you do the redo pouch procedure itself, it is a complex problem. Most of the time, quote unquote, the leak and abscess that labeled as a Crohn's disease that caused the failing pouch needs to be excised. And then the pouch needs to be disconnected. This area needs to be cleaned with the mucosectomy, which is stripping the mucosa, taking it out, and a new anastomosis needs to be done. Why I'm saying that thing? Because you're going to see a lot of lesser involved procedure to be done in these settings to help the patients from the bottom. It's okay to fix these problems from the bottom one time, but if you try to fix it 2, 3 times, those are the patients that's going to get into the problem itself. So this is some of the sad, frustrating, humbling potpourri that I had the privilege of taking care of my patients throughout the years. 9-year-old girl who was labeled as a obstructive Crohn's disease for years and was told to live with a permanent ileostomy for life, but never, and had a quote-unquote minimally invasive laparoscopic surgery. By the way, laparoscopy is very good, as Marla said, as long as done right. But to ignore the principles of the correct surgery just to have a shorter size of incision is really not the biggest, is not a service to our patient. So then I convinced the family, we got to take a look. What happened is when they did the anastomosis laparoscopically, the pouch itself valvulized and around itself 360 when they stapled the pouch to the anus. So every time they closed the ileostomy, by the way, which they did twice, patient was getting acute bowel obstruction, and she was told to go ahead and live with it because you have some Crohn's disease obstructive or a pelvic floor disorder. So a lot of things is happening in the pouch surgery where the pouch surgery gets labeled as the wrong thing to do. I won't blame the patients because we have not centralized the pouch surgery or the IBD surgery care, because as what I said, the IBD surgery subspecialization is a further subspecialization that needs to be considered for anybody who has the privilege of taking care of these patients. This is another patient of mine. He was referred from Boston. Patient had a long-standing ulcerative colitis and proctitis, can be seen here. So the patient had a J pouch, but what he had was a total proctocolectomy. Rather than an ileal pouch anal anastomosis, he had a ileal pouch rectal anastomosis. So the thing that what we talked about and Marla emphasized, that miserable urgency and everything, that the rectum is still there. This patient's back to where he is. And would you blame him when he or she gets a mistrust to R because of the fact that what he had to be done was not done? And by the way, my father was a surgeon, and he always used to say, don't ever be critical of your colleague's complication, because the same thing can happen to you the next day. So I'm speaking that with that humility here. But we also need to understand that this is really not that difficult, that somebody left 10 to 12 centimeters of rectum behind. So this is, again, another twisted pouch, plus the meso of this patient was left behind there. And this is a quick video of a young man that was sent. Can be seen here that we are, mobilizing the leftover rectum again, the metal part where the rectum was, and we were able to double staple it again. What does double staple it again means? We were able to go lower in the rectum to be able to do another pouch anal anastomosis. They left the rectum behind, labeled as Crohn's disease for years, and now that was actually a true mechanical problem that could have been fixed before. This is another patient of mine that from Chicago that came, and this was, again, years of bowel obstruction, Crohn's disease, failed pouch, and these are the patients really suffered a lot. Can be seen here, again, the same problem, laparoscopic approach. The pouch was 180 degree, twisted itself. Can you imagine living like this? And saying that it's all in your mind? That is really the thing that we had to fix. So when we look at our results here, that the redo pouch procedure of failed pouch can be done. This is over 100. If you advance to the next slide, please. When you look at these results, the results of it is pretty good, actually. Over 10 years, that 82% sustainability of a redo procedure. But this was a trans-abdominal approach. The quality of life itself is pretty good. You can see here, you can say that why these patients are suffering like this. But that's their judgment. They're better than before, because when you ask them about the redo procedure, most of these patients actually are very happy that they underwent this procedure, and they would recommend the surgery others in the same position. This is also in the setting of the Crohn's disease. I'm getting more liberal about this thing. This is a redo pouch in the setting of likely Crohn's disease. We look at our results in patients who had a J pouch in the setting of a primary Crohn's disease and in the setting of a secondary Crohn's disease. And I don't want to give you an impression of the fact that I'm doing J pouches right or left in patients with Crohn's disease. All I'm just saying is there are 3 categories of Crohn's disease. In the past, we used to do 2-stage pouches on the patients where the pathologist said, you guys were wrong, this is Crohn's. Those patients did well. Certain selective patients with limited perianal disease, no small bowel disease, initial colectomy specimen showed Crohn's disease, proper consenting with the J pouches in that setting where the diagnosis of the colon specimen came Crohn's disease, they did well. Patients who did not do well are the 3 to 9% of those patients where the pathology, everything picture perfect, was ulcerative colitis. Later converted to Crohn's disease, those patients did not do well. And this is the point that I'm trying to make, that when we focus on these patients, that I think we need to be having a little bit more open-minded the possibility of a pouch or a redo pouch in these settings. So when we look at these results, there were 2 groups, as what I said. Index pouch in the setting of a Crohn's disease, or the patients redo revisionary of IPAA. When we look at these results, what we found, the fact that 360 patients, the 253 were the index IPAA, 53 was the redo pouch on a Crohn's disease. Now, the problem is what exactly we're calling Crohn's disease of the pouch, that's as a failed pouch, what exactly we're calling the mechanical problem of the situation. That is the biggest dilemma, because most of these patients, when they come to us, we do the 3 workup: MRI of the pelvis, gastrograph and enema, flexible pouchoscopy, and exam under anesthesia. Some patients may have both. So that's something that I think needs to be addressed to the patients. When we look at these results of these patients as an index pouch and a redo pouch in the setting of a failed, the pouch with a Crohn's disease, they both did well. Functional outcomes was also very good. But the long-term results, patients need to know the fact that their 10-year survival rate of their pouches in the setting of Crohn's disease around 38%. But for many young patients who don't want to have an ileostomy for a while, that 10 years of 40% may look like 100%. It's all about open, fair, transparent discussion with our patients. I think in the setting of the failed pouch, where the patient's diagnosis may be a Crohn's disease, this can be a good option to consider. I do have 20 patients experience in the setting after a vigorous consenting, and most of these patients are doing well. When we look at our recent results, what we found the fact that at the NYU, the last 2 years, that we had 92 redo pouches and 95 index pouches IPAA. We look at the results, the failed pouch, that when you do a redo pouch, they do have a same morbidity and the good results compared to the index pouch. So I think what we need to talk about when we look at these results, that what exactly we're talking about a failed pouch. What are the reasons of this failed pouch? My biggest suggestion or the message to you today, and I beg you to hear me, because you are the one who will be managing these patients. When we look at this over 500 patients who had a redo, 80% of these patients were referred to me by the gastroenterologist, not the surgeon. This is what I'm trying to say. The surgeons have the ego greater than the Mount Everest. So check your own footsteps. If there are issues happened within the time of the surgery, and if the issues started within the first 6 months after the surgery, these are very, very likely a mechanical or technical issues that can be fixed, and these patients can have a great outcome and results in the setting of the redo J-pouch procedure. Thank you so much.